Today, we're going to talk about Chapter 55, which is the prenatal diagnosis of congenital anomalies. Now, I know throughout this time that we've kind of skipped around a little bit, but I felt like I wanted you guys to learn more about the different anomalies that can happen in each organ before we put them into like chromosomal abnormalities, because it seems like with these chromosomal abnormalities, there's multiple congenital anomalies from different organ systems in the fetus. So that was my reason why we're going to do these last two chapters at the end. So major congenital anomalies are found in 3 of every 100 births. So about 3% of babies have some kind of congenital anomaly. 10 to 15% of births are complicated by minor birth defects. And sonographers screen for unsuspected anomalies and study at-risk fetuses. That's what we do. When a baby is diagnosed with a chromosomal disorder, there's like a multidisciplinary team that is going to work with the fetus and the mom and dad to make sure that they have the best treatment that they can. So you have a perinatologist, which is like the maternal fetal medicine doctor. That's who I work for. A neonatologist consults with them. So like a NICU doctor to kind of explain what's going to happen after delivery. A sonographer, a perinatal sonographer, so a high risk sonographer. A pediatric surgeon if needed. They will go, usually pediatric surgeons are at higher centers, not in Wichita. So when there is a birth defect, like a heart anomaly, they're going to be sent to a higher center. Like a lot of our patients go to Children's Mercy and deliver up there. Other pediatric specialists, a geneticist, they are always going to be referred to like a genetic counselor that's going to work with them to talk to them about risk for other children or what possibly could have happened that they had this chromosomal abnormality. Of course, the obstetrician who is going to deliver the baby, and then we do have social workers involved to kind of help, and other support personnel. So it's like multiple people that are going to help when this is going on. There's multiple different kinds of genetic testing. A lot of times now we do what is called the free fetal DNA test. And that can be done really early, like 10 to 12 weeks. It's a blood test. A lot of people do it to screen for the most common chromosomal abnormalities, but also you can tell the gender at this time. So this is how people can find out what they're having really early on. If for some reason the free fetal DNA comes back and says, they have a higher risk of trisomy 13, trisomy 18, trisomy 21, then these other tests kind of come into play. So chorionic villus sampling is ultrasound directed biopsy of the placenta. We don't do these as much anymore, but the reason that this is beneficial is it can be done early. It can help to diagnose biochemical metabolic disorders, thalassemia and sickle cell disease. It's an alternative to the amniocentesis, which is what we do at our clinic more. The advantages of a CVS is performed early in the pregnancy, 10 to 14 weeks. Results are available within 1 week. Earlier results allow for more options for parents. So some people go through the vagina and they take a sample there. You can also go through the belly for this. Ultrasound performed before actual procedure should aid in the following ways: determine relationship between live uterus, cervix, and pathocatheter. The bladder fullness influence relationship. Assess for fetus in terms of live, normal morphology, and age, and identify uterine masses that could interfere with the passage of the catheter. So this is what a catheter looks like. It goes into the placenta and takes a sample. What we do more at our clinic are amniocentesis. These are offered around 16 weeks, so a little bit later on. The reason why is they want the chorion and the amnion to fuse before we do an amniocentesis. So the tests offered to patients at risk for chromosomal abnormality or biochemical disorder that may be prenatally detectable. The results are available between 1 to 3 weeks, but a FISH result can be available within 24 hours. So they the FISH assay most commonly evaluates for numeric abnormalities or chromosomes such as 21, 13, 18, X, and Y. Advanced maternal age is common reason for amniocentesis, but most of the time we do amniocentesis if there is a free fetal DNA came back and said it's positive for trisomy 21, 13, 18, because the free fetal DNA is not definitive. And amniocentesis is going to be a definitive thing. So because they are taking amniotic fluid from the baby from the womb, and that's going to give your best definitive diagnosis of a chromosome abnormality. So the risk of having a fetus with Down syndrome is 1 in 365 in women 35 years of age. A risk of women 21 years of age is 1 in 2,000. I've seen it all over. I've seen young people have Down syndrome babies. I've seen older people have Down syndrome babies, but you do have a higher risk of having a Down syndrome baby if you are older. If you're advanced maternal age, which is 35 years, which makes you young women who are older than 35 years of age feel like ancient people, but it's just part of life. Your follicles get a little bit older. They're not as healthy, and so there is a higher risk for chromosome abnormalities. The risk of having a fetus with any chromosomal anomaly is 1 in 180 in women of 35 years of age and 1 in 500 for women of 21 years of age. Now, I've talked a little bit about this with you guys. It seems like our society has children later than they used to. We kind of have changed, but because people go to school, get an education, um, just seems like people want to do more things before they have children, and they have different options now. Um, Back in the day, people had younger, they were moms younger, and like way younger, like 15, 16, back in like the 17, 1800s, 1600s. Our bodies are actually probably more fertile at that time, like teenage, early 20s. Um, so our makeup in our bodies, we're supposed to probably reproduce earlier than what we are now, just because our society has changed and people have they have they put off having children for careers, and just our society's changed. um but our bodies haven't. So people who do wait tend to have a harder time getting pregnant because we're not as fertile as we get older. And then on top of that, they have a higher chance of having a chromosome abnormality. Hence, egg freezing and other things that are coming up where you can actually harvest your eggs early, like when you're in your 20s. Keep those eggs, those healthy young eggs, for when you're ready to have kids. If you're ready to have them at 40, you have your 25-year-old follicles waiting for you, frozen. Now, it's not always guaranteed that it would work, but that is kind of what they're starting to develop more um, avenues for having healthy children if you want to wait to have kids. Now, saying that, I have a lot of I think, young friends who are 35 to 40 that have had perfectly healthy kids. I've actually scanned 45-year-olds that are have healthy babies, and so it's not a guarantee that something's going to go wrong, but you just have a higher chance. Off my soapbox now and back to our PowerPoint. I'm not even on a soapbox. To be honest, like I'm just saying this is just how it is. Okay, so other indications for genetic amniocentesis. History of balance rearrangement in parent. If a patient has a chromosomal abnormality, they have a higher chance for their kiddo to have it. History of unexplained abnormal AFP level or a fetus with a congenital anomaly that other than, if we see club feet, tetralogy of flow in the heart, you start thinking if there's multiple different things going on, it's probably going to be a genetic abnormality. Okay, so amniocentesis genetic reasons 15 to 20 weeks. We like to do it after 16 weeks at our place. May be done as early as 12 weeks, but could lead to fetal scoliosis or club foot. Secondary to reduced amount of amniotic fluid afterwards. So they like to make sure there's enough amniotic fluid. So the procedure should include fetal survey to exclude congenital anomalies. Usually what I'll do is I'll scan the baby first. If we're just doing the amniocentesis, I'll just scan, make sure baby's viable, get a heart rate, get a fluid, kind of look through where a good place would be to put the needle and the catheter in. Then I'll show it to the doctor. The doctor will take a look. He'll usually decide different, it seems like, but I do give it a good shot. And then I'll hold the probe while he inserts the needle. Now they don't numb this poor lady because he says he can't really take away the part that hurts. So he just sticks a needle in there with the catheter, sticks it through the uterus. The catheter goes in. The catheter is soft like a straw. You can see the baby kind of play with it sometimes. And then we take out some amniotic fluid. After the procedure, I usually take a heart rate and MVP, just make sure there's still enough good fluid, and then we are done with the procedure. They say that we can get some fish results within 24 hours, but 1 to 3 weeks is the how much it usually takes. So optimal collection of amniotic fluid would be away from the fetus, away from the central portion of the placenta, away from the umbilical cord, and near the maternal midline, because you don't want maternal uterine vessels to get in the way. So this is the genetic amniocentesis technique. You'll see the catheter will look really hard to see at first, but then you'll see a little white line going through the placenta or through the uterus, and it will look like a little white straw like this. Preliminary sonographic examination for each fetus should be performed to include survey of fetal anatomy and growth profiles. And with multiple gestations, you determine whether the pregnancy is monozygotic or dizygotic. And if you want to do amniocentesis on twins, you will have to make sure you're in the right sac, which is difficult. They will inject dye into the first sac to show that both sacs are sampled. So they'll put dye in the first sac just so we know that we are on both sacs. So one will look more purple and the other one will look like more yellow, because that's what amniotic fluid looks like when it's taken out. If dye stained fluid is visible, it indicates the first sac is penetrated second time. Okay, I think that's enough for that. Because I really want to get to the good part. So chordocentesis, maybe just look over that. It's another method to analyze chromosomes. We don't do that here, but it is commonly used for guidance for transfusions to treat fetal isoimmunization. So if the baby has fetal anemia, they might do a chordocentesis. A little bit about AFP. I want you to know that amniotic or alpha fetoprotein is a major protein in the fetal serum. So if you have an elevated alpha fetoprotein on lab work, it could potentially mean that there is some kind of opening in the baby. So we're talking about neural tube defects, omphalocele, gastroschisis, just everything that we have learned about, any kind of opening, cloacal exstrophy, bladder exstrophy, any kind of levels that are increased, MSF, AFP, could be some kind of opening within the baby. So that's something that you should probably, if you have an indication that says elevated MSAFP, that should be in your mind that, okay, I'm looking for some kind of thing that is making the AFP increase. So I'm looking for neural tube defect. I'm looking for any kind of abdominal wall defect, kind of things like that. So that's what I want you to know about alpha fetoprotein. Limb body wall, amniotic band syndrome. AFP level in twin pregnancy will be twice the singleton because two fetuses make twice the AFP. That makes sense. So obstructions of GI tract may cause reduced clearance of AFP. So may explain elevations with anomalies like annular pancreas, esophageal atresia, duodenal atresia. Fetus with a kidney lesion may produce AFP. Polycystic kidneys could lead to higher AFP. Fetal death is frequent with cause of high MSAFP. We don't really do a quad screen anymore, but I want you to look that over. We do first trimester screenings. Do you remember the nuchal translucency screen? So we will scan a baby 11 weeks to 13 weeks, 6 days. We will look at the back of the neck, measure the nuchal translucency. We want it less than 3 millimeters. I want you to know that. On top of that, they will be getting blood work, and they will be getting looking at the pregnancy associated plasma protein A and the beta HCG. And together, the free beta HCG and the PAPA A being evaluated in combination with the nuchal translucency measurement in the first trimester is a sensitivity screening tool for Down syndrome, trisomy 18 and trisomy 13, actually. And so they won't say, yes, definitely the baby does or does not have one of these trisomies, but it does give you a risk analysis. So on mine, I did one with my first kiddo, and it said like 1 in 18,000 for everything. So I thought, okay, that's pretty good. So, and then obviously she turned out to have normal chromosomes. When the PAPA and the HCG assessments combined with information regarding maternal age and nuchal translucency, detection rates for Down syndrome reported to be greater than or equal to quadruple screen. So that's why we like to do the NT screening. Okay, now for the fun part. Medical genetics. I really think medical genetics is so interesting, and I think that's why I like this chapter so much. So normal karyotype consists of 46 chromosomes. So we have 22 pairs of autosomes and 1 pair of sex chromosomes. Aneuploidy is abnormality of the number of chromosomes. So one of the most common aneuploidy conditions is Down syndrome. An individual has an extra chromosome of number 21. Here are our chromosomes. These are normal. So this is a boy, XY. And then you can see there's 2 pairs of each one. The cause of trisomy is usually non-disjunction, failure of normal chromosomal division at time of meiosis. And the cause of non-disjunction is unknown, although strong association is with maternal age. chromosomal disorder is caused by too much or too little chromosomal material. The dominant disorder is condition caused by a single defective gene. Autosomal dominant is usually inherited from one parent, but may rise as a new mutation. Inherited dominant disorder carries 50% chance that each time the pregnancy occurs, the fetus will have a condition. So recessive disorders are inherited by one parent, and each pregnancy parents have a 25% chance of having a fetus with this disorder. So this would be an autosomal recessive condition such as infantile polycystic kidney disease. X-linked disorders are inherited by boys from mothers. So affected males do not transmit disorders to sons, but all daughters will be carriers, which is really interesting. Sons of female carriers have a 50% chance of being affected. Daughters each have 50% chance of being a carrier. So X-linked disorder, there's multiple. There's factor X, but also aqueductal stenosis. So you can look those up if you're interested. Multifactorial condition is a abnormal event that arises because of the interaction of one or more genes and environmental factors. So anencephaly is one of those. There's multiple things. Could be genetic, could be folic acid deficiency, could have been insult in the first trimester. Mosaicism is interesting because it's occurrence of gene mutation in some of the cells, so not all of the cells. It's difficult to predict types of problems that will occur when mosaicism is found. So the chromosomal abnormalities that we're going to talk about today are 1 in 180 live births. So it's pretty rare, which is great. And again, the nuchal translucency, NT reported as late first trimester finding identified 10 to 14 weeks. We like to do it around 11 weeks to 13 weeks, 6 days. If there's more than 3 millimeters, that's considered abnormal. NT increases with gestational age, and the NT measurement should be compared with gestational age and the crown rump length. So when you are doing a nuchal translucency, you're also going to measure the baby's crown rump and write in there how many millimeters it is. And so they take into account all of this different stuff when they're doing their odds. Here's a very thickened nuchal translucency there. So on top of it being a chromosomal abnormality, you could also just have a cardiac defect, a diaphragmatic thing, a renal and abdominal wall anomalies. I had a friend who had an increased nuchal translucency and the baby had a small heart defect, but overall the chromosomes were fine. Increased NT has spontaneous increased risk of spontaneous miscarriage or perinatal death. Okay, my favorite. Let's talk about the trisomies, the different ones. Now we can put everything together that we've learned. So trisomy 21, if there's an extra 21 chromosome, these are some of the things that can happen. Nuchal thickness could be thickened, hygroma, heart defects, duodenal atresia, shortened femurs, mild pileectasis, mild ventriculomegaly, which is greater than 10 millimeters in the head, echogenic bowel, and absent nasal bone. Now you guys should all know what these are now. Here they are. This is everything that you could potentially see on trisomy 21. Now they don't always have all of these different things, but these are some of the indicators. So here's on your left, the normal NT thickness and an increased NT thickness. With Down syndrome, you can also see this baby does not have a nasal bone, and this one does. You remember this double bubble sign, duodenal atresia, a shortened femur bone, less than the 5th percentile. A heart defect, there's multiple different heart defects that go along with trisomy 21. Tetralogy of Fallot is one, but also a AVSD, which is atrioventricular septal defect, is a high increase with trisomy 21. Mild pileectasis, so nothing that's hydronephrosis, but just a little bit of dilatation in the kidneys. Echogenic bowel, absent nasal bone, and mild ventriculomegaly that is greater than 10 millimeters. Here's another little thing. So the baby's facial structure will be a little bit different. And you can kind of pick out Down syndrome kids just because of how they kind of all look. They have that same look. It's a flattened nose, face slanting upward, slanting eyes. They'll have a single palmar crease, short fifth finger that curves inward. Widely separated first and second toes, increased skin creases. These are difficult things to see on ultrasound, but after they're born, here we go again. Like they'll have that fifth finger, that small hypoplastic ears, fissured tongue. This is showing the chromosomes. Here's some images of them. Trisomy 21. My mom is a special education teacher, and for her last 10 years that she worked at a special school like called Chisholm Life Skills, where after they graduated from high school, they go, some special ed kids go to learn life skills. It was really cool. And she had a group of Down syndrome kids, and I got to come volunteer there, and I just like really just love them. They're awesome people. They're just so encouraging and happy, and they have their own little language, and I just really think they're amazing people. So I have a soft spot in my heart when we scan these kids. So trisomy 21, that is. Trisomy 18 is known as Edwards syndrome. I'm a Twilight fan because I've talked about this before. So how I remembered this was Edward from Twilight the vampire was 18 years old. Hey, I got to do what I got to do when you're learning all these different stuff. So it's the second most common chromosomal trisomy, occurs 3 in 10,000 births. So it's very rare. However, I feel like we see this all the time. But that's because we're maternal fetal medicine. The karyotype demonstrates extra chromosome 18 associated with abnormal quadruple screen. So multiple things happen with trisomy 18. Heart defects. I want you to know choroid plexus cyst is a huge thing for trisomy 18. So note that. Clenched hands, micrognanthia, small chin. Those three are huge. The rest of these do also occur. Omphalocele seem to occur more when trisomy 18. So just to note that. Here's some choroid plexus cyst in the choroid plexus. And here's the rest. You'll have a possible cleft lip, heart defects like hypoplastic left heart, choroid plexus cyst. Clenched fingers is a huge thing for trisomy 18, so I want you to know that. And omphalocele is huge, micrognanthia, small chin, kidney defects, club feet is huge, especially bilateral club feet. And here's just another picture of the clenched hand. This is a trisomy 18 kiddo afterwards. Now, a lot of these babies don't survive, but there have been some that have lived past their year. Fetus with trisomy 18 might spontaneously abort. Infants have profoundly retarded and consider lethal anomaly. Considered a lethal anomaly with 90% of infants dying within the first year of life. Trisomy 13 is known as Bateau syndrome, and it occurs in 1 in 5,000 to 20,000 births. So it's a lot more rare, and it's a lot more severe. Trisomy 13 is where we get all of our midline defects. So the cyclopia, the proboscis, the holoprosencephaly, the polydactyly, the ones that is just shocking to look at that we looked at in our facial. chapter, these occur most with trisomy 13. So here we go. Trisomy 13 has holoprosencephaly. You remember that proboscis, multiple fingers, cyclopia, bilateral cleft lip is huge with trisomy 13 and a small chin. On top of that, they also have like heart defects, renal anomalies, just talipes. I mean, all the other things, but those are the main things with trisomy 13. This is showing a holoprosencephaly. You can see there's just black here, anechoic. The brain did not rotate correctly. Multiple finger, more than you think, 6 fingers on each one. And phallicil also can occur with trisomy 13. Cleft foot, club foot. The prognosis for trisomy 13 is extremely poor, with 80% of infants dying within the first month, and it's considered a lethal anomaly. Here is an image of trisomy 13. Now, each case is different. So here is a baby that had trisomy 13. Some are more severe than others. Triploidy is the result of complete extra set of chromosomes, and it often occurs as a result of an ova being fertilized with 2 sperm. It's estimated to occur in approximately 1% of conceptions. Most fetuses would spontaneously abort in the first trimester, and only 1 in 5,000 will continue to 16 to 20 weeks of gestation. So we don't usually see triploidy in the second trimester because most of those babies have it's been a miscarriage or spontaneously abort. However, if you remember, triploidy can occur in partial and complete molar pregnancies. And complete molar, you're not even going to have any fetal tissue. It's just going to be that hydatiform placental degeneration. If you can really think back, it could also turn into a malignant form called choriocarcinoma. If it's a partial mole, then the triploidy fetus will have heart defects, renal anomalies, and phallicil cranial defects, facial defects. These usually abort, though, in the 8 weeks, around 8 weeks. Mosaic form of triploidy may be compatible with survival. Infants affected will have mental retardation. Turner syndrome is one I really want you to know too. And Turner syndrome is 45X. So it's marked by a genetic abnormality in which there's an absent X or Y chromosome. So it'll just be 1X. With girls, we want to have 2 X's. So it's not associated with advanced maternal age. It just kind of happens spontaneously and occurs in 1 in every 2,500 live births. These, with Turner syndrome, the huge ones that you're going to think about are hydrops. So you're going to have increased fluid within the baby in at least 2 spots. So fetal ascites, pericardial fusion, pleural fusion, anasarca, which is extra fluid around the head, cystic, hygroma, heart defects, and renal defects. Other physical features include cardiac anomalies, which is coarctation of the aorta is the most common. General lipedema and hydrops may be present. So I think about with Turner syndrome, just an increased amount of fluid within the baby. Most fetuses with Turner syndrome will spontaneously abort, but some will survive. So here's a large cystic hygroma in the back of the neck. This baby also had increased fluid just around skin lymphedema. If the hygroma is isolated, it may regress in utero. Female infants who survive will have immature sexual development, amenorrhea, short stature, web neck, cubitus valgus, shilled chest with widely spaced nipples. They may have poor hearing, hormone replacement necessary for sexual development, usually have normal intelligence. So what you're going to see on ultrasound is a cystic hygroma. You might see increased fluid around the baby. And if you're later on, you might see coarctation of the aorta. Cystic hygroma, remember, you're going to have those nuchal ligaments in the back of the neck. This is a pleural effusion around baby. Here's an image of this, Turner syndrome, missing the X. This is what a person would look like if they did survive. And I think that's it.
Quinny's making him lunch.